So what we're going to start off with today, our first panel, is really how do how does one find out that they have breast cancer? And what is breast cancer? And then how do we move forward for local control and really increasing survivorship? The mortality of breast cancer has decreased, but the numbers have not. And I will tell you what's striking to me. I've always cared for pregnancy-associated breast cancer and young-age breast cancer. I've been doing this for over 40 years. But it's striking to me in the past 6 months, great bulk of my patients are between the ages of 20 and 35. So we really have to look at that and try to understand what our life goals are, what our lifestyles are, what our environment is, all of the above. And I can't explain it. I don't have an answer. We're seeing it in pancreatic cancer and colon cancer and other cancers. But I'm going to start this off with just a brief story, and then we're going to kick it off to the panel, and I'll introduce them. Some of you have heard this, who have heard me speak before, but in my first week of my first year of medical school, first Thursday, our whole group was signed every Thursday afternoon to follow in the community somebody with an MD or a DO on the back of their name. Why? Were we going to learn orthopedic surgery in one afternoon, psychiatry, family medicine? No, it was to learn the pearls, how to knock on the door, be respectful, speak the language in a fashion that the patient would understand and you would understand them. Listen to the story. I'm assigned to a medical oncologist up at Roswell Park. And I showed up that first day, and we're talking a long time ago, back then when the charts were on the door with all the information of patient facing outside. It had the name of the patient, their date of birth, what they were diagnosed with, and sometimes in red they write, the parter is awful, don't let them back here. Anything could be on that, everybody to see. It was pre-HIPAA. The nurse came over to me and she said, "You're going to meet a patient, 77 years old, diagnosed with breast cancer 7 years ago. And she had a mastectomy. She had a surgery. She didn't say mastectomy. She had a surgery, and she's coming in from farmlands about 4.5 hours away for her 6-month well care. Trigger. So I went in. What was I going to talk to this woman about? I knew nothing. We talked about her farm and her harvest and her family. I looked under her robe, and there was only one breast. And I stepped back and waited for my attending physician to show up. Back then, we present the case, and we would go into the room together and we would see how the case should be addressed. And my attending said to me, "Tell me about the patient." I thought I was so slick, so smart. I said, 77-year-old diagnosed with breast cancer 7 years ago, mastectomy, here for 6-month well care follow-up. I thought I should get an A++. I said it all in 15 seconds. Until she said to me, "What does a mastectomy look like?" Well, I said, "It's the absence of a breast, and there's a scar that starts in the middle of the chest, and it runs up and down in a raggedy fashion from all the way up to the collarbone, all the way down to below, above her abdomen, to her armpit." She said, "Really?" She said, "Let's go in." And she asked the woman, "Can you tell this young," I was young then, "tell this young doctor how you lost your breast?" She said, "Oh, dear," she said, "I was helping my son on his farm. His wife was about to have a baby. It was harvest time. And as I bent over to pick up my basket of whatever it is, I still, all these decades later, don't remember. As I bent over, my breast fell off." This woman had never been to a physician in all of her life. All of her children were born on the farm. She had a lump in her breast dating back about a dozen years before this event. She thought it was a boil. Sliced potatoes, sliced cucumbers, everything holistic. It didn't pain her. This thing grew and grew until it replaced her breast, and this piece of stone, just by sheer gravity, when she bent over to pick up that basket that day, pulled away from her chest wall. The family drove her. You're supposed to go, "Ah." The family drove her immediately to the big city, got rolled into the operating room. They cleaned the wound. There by the raggedy incision, they took out 22 lymph nodes. 22 lymph nodes. Should I ask you guys how many lymph nodes were involved by cancer? I'm not gonna ask you. 0. None. And this was before radiation to the chest wall. This was before tamoxifen was approved in the adjuvant setting. And there she was coming every 6 months for a hello. And I thought, well, what's the big deal about breast cancer? Until that afternoon, I sat quietly listening to my physician, who became my mentor, interview a 32-year-old patient who was diagnosed with a stage 1 breast cancer just under 2 years before. She was there with her husband and her parents. She exploded with metastatic disease within a year, and they were there to discuss end of life. And she did die 2 months later. We didn't know what HER2 was back then. We didn't know how to triple negative. We didn't even understand anti-estrogen therapy. I went home that day and I knew 2 things. That number one, breast cancer was a lie, and Anna, this is going to be your introduction. Breast cancer was a lie. It was not one disease. It was multiple diseases. And second thing was I was hooked. That was it. I was going to be the Columbo of breast cancer. But with all seriousness and all respect, I have never been bored. I relish every day that I come in to meet a patient, to the intimacy of that room, the stories that are told. I learned early on, not what's on a piece of paper. I learned early on what breast cancer feels like, smells like, acts like, and it behaves so differently, just like we're all different in this room. But we come a long way. Could I say we come a long way, baby? Yeah? Okay. All doctors smoked back then when I was training. So what I'd like to do is introduce our panel. This is Dr. Anna Boguniewicz near me, and she is a pathologist at Albany Medical Center. When I came up here 10 years ago, she didn't know. A lot of people didn't know. I vetted who I was going to work with and who I was not going to work with. And I knew that if Anna read and dictated a report on a patient, that it was equivalent to any of my Memorial Sloan Kettering pathologists. And she's been a great support, great boon for the patients up here. And Anna, I'm going to throw at you right now, what is breast cancer? And I'm going to take a back seat. So, is it working? Yes. Okay. Can you hear her? Yes. So that's a very loaded question, not easily answered, but pretty much to define it in very simple terms. Okay, hold it right here. So to try to define breast cancer in very, very simple terms, it's when a cell, a normal cell, acquires a type of mutation, a change in its DNA. So normal cells, we have trillions of cells in our body, and they are constantly breaking and repairing themselves. This is normal. This is how we exist. But there are regulations, and they repair themselves and they move on. In a cancer cell, that doesn't happen because they acquire its change in their DNA that allows them to just avoid the regulations and they don't stop dividing, and they continue to divide. And that is what cancer cell is. It's an abnormal cell that has acquired the ability to continue dividing and avoid the signals that tell them to stop. Ultimately, due to, again, changes in the DNA, these cells may acquire the ability to break past the walls that surround them. So the cells have, again, I'm just trying to paint a picture that perhaps you can understand. The cell is a matrix around them, and this prevents the cells from moving. But again, they acquire this ability. It could be due to genetic factors. It could be due to, external factors, chemicals, alcohol, smoking, and lung cancer, a variety of factors. They acquire this, mutation, this change, and then it allows them to break through these barriers that keep them in place and penetrate into the tissue that surrounds it. But then you say, well, some people have this happen to them and nothing happens. They don't go beyond that, right? Other people develop metastases. So it's a very fascinating and a very complicated system, because just because a tumor cell acquires this ability to invade doesn't mean that it's going to go anywhere, because the next thing is it has to acquire the ability to get into a blood vessel so that it can travel. Once it's in a blood vessel, it has to have the ability to evade our immune cells that are in there searching for these invaders and trying to neutralize them. So it has to develop that ability. Then it finds its new home. Let's say it ends up in the lung. Well, it doesn't just land there, it has to have nutrients. So it has to have the ability to develop blood vessels and to access those nutrients. So all of this actually is great, because it means that most cells that acquire this ability to become malignant, to invade, to metastasize, really don't survive. And only a very small minority of these cells actually, can metastasize and, establish a new location. So that's really what cancer cells are. They're just abnormal cells that are constantly dividing. Now, when I want patients, I tell them that if I buy a packet of seeds in a nursery, and I share the seeds amongst the 5 of us up on the stage, and we all go home to our individual gardens and plant the seeds, and then we're all going to get back together to talk about what grew. In one garden, nothing may happen. In another garden, the seed may germinate, but it doesn't have the potential to create a stalk and break through the soil. In another garden, there you go. Now you've got a stalk, you've got a flower, it looks real nice. But in the last garden, that stalk and that flower may create seeds, and those seeds may land someplace else. So it depends on the wind, the temperature, the soil, pH, the acid base, and similar things are going on in our bodies, because even with those seeds landing in someone else's garden across the way, they may not have the nutrients, they may not have the endogenous or exogenous hormonal factors, they may not have metabolic processes to allow these cells to thrive. So we know that these issues happen. Does everybody get diagnosed with the same packet of seeds? What are the differences in the seed packets that we purchase? Also, you may know that there are different types of breast cancer. If you've received a diagnosis, some patients have tumors that are called ductal carcinomas. Some patients have tumors that are called lobular carcinomas. Those are the 2 types that account for the vast majority of invasive breast cancers, and situ breast cancers that we deal with. There are many, many other subtypes as well, but they're just not as common. And I think the face of cancer in general is changing. For the longest time, for decades and decades and decades, we really relied on the morphologic findings in a breast cancer, and we identify those depending on what we saw on our slide. So in the breast, the breast has a series of tubes. They're called ducts, and they divide and become smaller and smaller. And then at the end, we have what looks like a grape, and that's a lobule. And we have the tumors that arose from the ducts, and because a duct has a lumen, these tumors form these lumens, so they looked like they came from a duct. The ones that came from the lobule did not. It was a different type of tumor. And so we really relied on morphologic findings. Invasive lobular carcinomas often tended to grow in a single file. because they didn't have this adhesion or this sticky molecule on their surface. So they tended to grow in single file or as single cells, whereas ductal carcinomas had a sticky molecule. And so therefore they stuck together. That is now changing. We still obviously make that diagnosis in our reports, whether something's ductal or lobular or mucinous or whatever. But very often with the treatment of tumors, what is more important are the genetic alterations that may be occurring, particularly in more advanced disease. But still, the standard of care is we diagnose it based on what we see under the microscope, which is really the way it was done 100 years ago.
Can you give us just a couple of words on the immunohistochemical interrogation? Breast cancers are estrogen positive, HER2 positive, or triple negative.
So most ductal carcinomas and lobular carcinomas will be both estrogen and progesterone positive. And the way we look at that, it's actually relatively straightforward message, but there are receptors, both breast tissue, uterine tissue, ovarian tissue, and many others, brain tissue, bone tissue, has receptors for estrogen, both in males and in females. And the tumors, since they arise from the breast tissue, may acquire receptors as well. And so we test for them. And what we do is we have an antibody, which is a specialized protein that is directed towards estrogen. And we pretty much in the lab, we have this kit, we stain it, and it turns, if there is estrogen on the tumor, will turn the nucleus of the cell, the center of the cell, brown. And then we look at slide and we say, okay, here's an area of tumor, and what percentage of these cells have those brown signals in the nucleus? And then we give a percentage. So if we don't see any, we will say that's negative. It's less than 1% of the tumor cells, we'll say that's negative. If it's more than 1%, we'll call it, if it's less than 10, low positive. If it's more than 10, then we just come out and call it positive. And, so that's how we do both estrogen and progesterone. HER2 is a little different. That is not a stain in the nucleus. That is a stain that is in the membrane, but the concept is the same. It is also an immunohistochemical stain in which we are looking for the protein that is produced. And so we are staining that protein found on the membranes of the cells, and we are looking for that and analyzing how many of those cells have that brown staining, and whether it is none, in which it would be negative. If there's some, depending on the setting, we would either call that negative or HER2 low. If it has some staining, but not enough to make it outright positive. It's not strong, it's not diffuse, and we would call it equivocal, and then it has to be reflexed to a fish stain, which is a different type of procedure.
Thank you, Ann. Thank you. Dr. Plitas.
Yes.
Yes, you. We're honored to have Dr. George Plitas, who is on the breast surgical service at Memorial Sloan Kettering Cancer Center. He's associate attending on the service, but he doesn't just go into the surgical arena. He is also director of research for the breast surgical service. And I have to tell you, when you start thinking about not just what you are there to take out and make sure that it's all removed, but when you start thinking about what it is and how it lives and how it acts, and how our immune systems get involved when someone does have the evolution of a breast cancer, that's when you want to talk to Dr. Plitas. So, George, you and I have known each other for years. Unfortunately, I'm still older than you, but what can you do about it?
Quite much.
Talk to me about when someone walks into your office. Tell me what goes on in your world.
Yeah. Well, it's often.
Is the microphone on?
Can you hear me? Yeah. It's obviously a very kind of scary time for patients, and And usually the surgeon will be the first person that sort of starts to explain the process and the disease to the patient. And I think that interaction is critical because the scary time, it's scary for a lot of reasons, but mostly because you really don't know what you're up against. There's a lot of uncertainty. And you're meeting all these people and you're entrusting your life in their hands. And it's scary, right? And one of the things that's important to try to mitigate that fear and anxiety is education. And I feel it's very important that patients understand this disease at the level that we understand it so that they can then be informed, be less scared, and make right decisions for themselves. And along those lines, it's important to understand how we think about this disease. And we think about it in two ways, therapeutically. There's local therapy, things like surgery and radiation, and then there's systemic therapy. We very beautifully heard that the problem with cancer, any cancer really, is that it can spread from where it starts to another part of the body. And the reason why this happens is because tumors shed tumor cells and they circulate throughout the body. And like we heard, those tumor cells may not know how to do anything and they just die in the circulation. They could land somewhere and just stay dormant or sleepy for years and, a decade later decide to grow out. But in many ways, that is the most important phenomenon with cancer, because if something was to grow somewhere else, everything becomes much more difficult to treat. And so what we do up front to prevent that from happening is what truly saves lives. And so the local therapy is important to get that cancer out, to stop future shedding, but more importantly, you have to address what's been going on already. And that's what the systemic therapy does. And in many ways, I always tell patients that your medical oncologist will cure this cancer. I'm just helping them along. So the systemic therapy is critically important. And that's where we've made incredible progress. And that's why women are surviving so long and are disease-free for the rest of their lives. And as a consequence of that, we can get actually away with less surgery, less local therapy, further improving the lives of our patients and the quality of life. So how do we figure this all out? Well, the local therapy, the surgery part, is pretty straightforward. We basically have to get the cancer out, and we have to sometimes assess what's going on with the lymph nodes. And mostly that's to help the medical oncologist pick the right systemic therapy. Sometimes we have a really good idea of what systemic therapy is necessary, and we might give it before surgery. So another thing that we have to kind of figure out in that first meeting with patients. And sometimes we give systemic therapy before surgery because we need that systemic therapy to shrink the disease so that we can get it out, maybe save the breast instead of having to remove it, maybe do less surgery in the armpit than we would have up front. Sometimes we give systemic therapy because we want to know the response, right? And so you get systemic therapy before surgery, then you have surgery and you know what happened. And in some cases, the disease is gone, and that's associated with good outcomes. And sometimes it's not gone, and that's less good outcomes. But then the medical oncologist knows this and is able to adapt accordingly and give adjuvant or after surgery systemic therapy in a very sort of personalized fashion based on that response. And so this all sort of happens at that initial visit. We just start this process. And it's very important that patients understand each step, why we're doing each step, rather than being told, just do this, do this, just do that, because that's where the fear and possibly even mistrust sort of sets in. So this is what I do, basically, when I first meet a patient. I kind of lay this groundwork down, set the expectations every step along the way. And I really do feel that creates a sense of empowerment in the patient. They've got more control over what's going on around them.
They become part of the team.
Yes, exactly. Very important.
George, I'm going to ask you a question only because it came in on the web. And I think it's really important because a lot of the research developed at MSK with Terry King when she was on the surgical surface looking at lobular carcinomas. Could you speak to the difference between classical lobular versus pleomorphic lobular? For a long time in my early career, I would see lobular cancer and say, oh, good, the lazy one. Yeah. Nothing to worry about. I just can't see it well on imaging.
Right.
But we began to understand over the past maybe 10 to 15 years, there's a pleomorphic subtype. And could you just speak to that a little bit?
Yeah. In general, there's a spectrum of, for lack of a better term, aggressiveness in breast cancer, right? And aggressiveness can mean a lot of different things. One thing it means is that these tumor cells in aggressive tumor grow faster and divide quicker than in a less aggressive tumor. And so there's this spectrum that exists. And historically, we relied on the pathologic evaluation of tumors to understand this. We look at them under the microscope, and depending on how ugly they looked, they said, oh, okay, this is an aggressive tumor, a fast-growing tumor, versus this is a slower-growing tumor. Along the spectrum is a subset of cancers called lobular cancers, which we just heard of, potentially originate not necessarily from the ducts of the breast, but from the lobules, the kind of breast that makes milk. And then these lobular cancers, some are slower growing or lazy tumors, and then there's a small rare subset where they're actually quite aggressive and ugly looking under the microscope. And so we call these pleomorphic lobular cancers. Pleomorphic is just a fancy way of saying they look ugly under the microscope. And they act differently, but these days we actually have pretty good tests other than how they look under the microscope to understand their aggressiveness so that we can treat them in a personalized fashion. For instance, chemotherapy use oftentimes was decided on things like tumor size or if it looked ugly under the microscope. Well, these days we have better indicators for benefit of chemotherapy. One, for instance, is a
For
test.
years and years, we had Peter Paul Rosen's paper on our desk in medical oncology. And if a tumor was just 1 millimeter over a centimeter, they all got chemotherapy.
Right. And so now we're switching to this idea of, well, maybe biology, not this arbitrary size, will dictate the need or benefit for chemotherapy. And there's this test that was developed called the Oncotype, and it generates a score. The score is validated in 2 big clinical trials now, and it tells us patients will benefit from chemotherapy. So if you look at the spread of Oncotype scores on this range of lobular cancers, you can clearly see that the pleomorphic lobular cancers tend to have very high Oncotype scores, and the classical lobular cancers have lower scores. And so pleomorphic lobular cancers are ugly, but they're treated differently. They chemotherapy. We now know the patients benefit from chemotherapy, and oftentimes they may not have the same expression profile of those receptors that we were talking about as classic lobular. So they can be too positive, or they can even be triple negative lobular cancers, where we even might give immunotherapy for them, treat them. So these days, other than just the way they look pleomorphic under the microscope, there's other biologic tests that we use to try to understand how we can treat them specifically.
Perfect. And you all in the audience are allowed to come to the microphone and ask questions. If you're shy, but you're thinking of something, I promise you there are at least 20 others thinking the same question. I've gotten a few questions in through the portal that I will address today in various disciplines. Dr. Iyengar, I can tell that 99.9% are going to be directed to you, so get ready. Thank you, George. Thank you so much.
Pleasure.
I'd like to keep in the breast surgical arena and introduce Dr. Loren Rourke, who, Loren, I think we should switch shoes. Those shoes would look great with my outfit. They really would.
And you know what? Maria and I are the same size. So I better hold on tight or she'll end up leaving with my shoes.
Closet multiple times. In saying that, Loren Rourke is a breast surgeon. And she's from Houston, presently. But she is someone who is known for her compassionate yet straightforward approach. She's empathetic. She can be funny, even where you would think, wow, how does funny happen here? And have a patient walk out actually with a smile, knowing that they're curable, they're treatable, we're in this together. And if you took note of a book that was on your chairs called Real Talk, Real Hope, Dr. Rourke authored this book. It just came out, I believe, in the late winter on Amazon, and she's already been interviewed by Fox News. So we're going to see her on the Kelly and Mark morning show and all sorts of other things. I'm not going to ask you about breast surgery. I'm going to ask you about the book. The book. I know the book. And I will say, I don't think it's just for breast cancer. I think anyone who wants to build tools on dealing with information that's unexpected. My property got flooded 3 days ago. We lost all of our gardens, and I learned something important. I'd better learn how to swim. So now I have a tool. But Loren, you sat down with thoughts that led to the writing of this book. Please tell us about it.
Well, I've been doing this a while. I'm old too. I will say that, being in this field for 20 years, I think George would agree, we are that first meeting with patients. And I've listened to so many stories and questions and concerns over the years. And when my mom went through her breast cancer journey, it changed me as a daughter, as a caregiver, and most importantly, as a doctor. And I wish I could say that our healthcare system works perfectly, but I think we all know it doesn't. It is broken. And the last 3 years, I started to get the nagging feeling like I needed to tell my story, that listening to my patients, learning from them, and watching my mom, there's information out there that I feel like every woman should have. And so nagging voice got louder and louder. I remember waking up one night and this tagline was in my mind: the club no one wants to join. And it stuck with me and it haunted me. And it is the club no one wants to join, right? Breast cancer. But having worked and been inspired with women who've walked this walk, there's something pretty special, though, about the membership to this club. And my patients always tell me, it's an elite membership. There is a bond there that's there for life with other women, with their family members. And so in my book, you'll see the club that no one wants to join. And then I got approached to write a book about something completely unrelated to surgery and breast cancer, but I said I want to do this one first. And I think when all the signs and all the planets line up, things happen the way they should. And even the cover, just for a second, the cover of the book is actually designed by a patient. And I'll never forget it. I was in the middle of finishing the manuscript, and we were at this critical 2 weeks that we had to design the cover. And if any of you have written a book, it's deadlines after deadlines. I mean, they're on you for everything. And when I got home that night real late, running the kids around, and it was at 11 o'clock at night, and I opened an envelope from a patient of mine, and it was a patient that happened to be a physician, and she had hand drawn and crafted the hand with the scalpel and a pen. And I remember looking at it, and I tear up now even thinking about it. I knew right then and there that was the cover of the book, because I'm known for one, Jordan, I use a scalpel. That's our tool. But the pen is my instrument with my patients in every first meeting. I draw and I write a lot. And she captured that in one powerful drawing. And so, she will always be part of my story because she's the cover.
I love you. I love your shoes more. You're going to have an opportunity to take your books at the end of the program today, and Dr. Rourke will autograph them for you. And if you have any questions for her at that time, I'm sure she'll be happy to address them. Dr. Oles, I have to say that on one level, I'm so thrilled to work with you on a daily basis. On another level, I will tell you when I bring up to any patient that I'm referring them to radiation, they yell at me. I've just finished my chemotherapy. Why do I need more? I just finished my surgery. Why do I need anything else? Dr. Theodoulou is a radiation oncologist. She's board certified, trained at the University of Syracuse. She's been with NYOH up in Clifton Park, and thank God, Patroon Creek, where I am in Albany, for a little over a decade, right? I've been with NYOH 20 years. Oh, well, double that amount. Double that amount. So, why do some patients need radiation therapy and why do some patients not? It's all yours.
Complicated question. Forgive me, I haven't had coffee, so if you hear some syllables rubbing together here, just bear with me. That is a complicated question, and it kind of goes back to what we've already spoken about, the individuality of not only the person, but also the disease itself. Lots of things figure into whether or not you need radiation therapy. The simple answer is whether you had a lumpectomy, if you had a mastectomy, was there nodal involvement? Were there delays in your care? Were there questions after the surgery about margin status? There are lots of things that figure into that. There's no dry answer to it. We know historically that women who have breast cancer will benefit from radiation therapy in the context of breast conservation. The nuances of that go past what you would normally think if you have someone who had a lumpectomy that has a myriad of other health issues that take precedence, where they are looking at a situation where their longevity is really quite in question from other disease processes. You may want to really think about whether or not radiation therapy is something they should consider. The caveat to that is that there are shorter schedules for radiation therapy, so there are lots of things to consider. Every now and again, I'll mention a patient that I treated who lived on an island in Lake George, because that's a thing. And there's no direct way to get to their compound without boat. So this rather elderly lady that I was talking to about radiation therapy certainly needed radiation therapy. She did not need nodal radiation, but she needed something to be done to the breast. At the time, we didn't have a lot of information about partial breast treatment. That large study that was done and finally completed, we didn't have any data from that. And she actually wasn't interested in it, mainly because she knows how breast cancer works and that we're talking about an entire breast versus lobule or duct, but I digress. In any case, she wanted treatment. She didn't want 6 weeks of treatment. This was a while ago before we had a lot of well-known hypofractionated courses, meaning shortened courses. So I did something that was a little unconventional at the time. We did 5 treatments to the breast at a dose that I really just had to do quite a bit of research to come up with because the data wasn't there at all, honestly. And she was so grateful because it took her an hour and 20 minutes to get to our office to go back home after, sitting in a boat for however long. I went through that very long and probably uninteresting story with you just to say that you are looking at individual people and their disease process and what they expect out of their treatment and what they want for their life, for their quality of life, because all of it matters. Something that Maria spoke about when she was talking about her early days in residency is everyone has a story. And I spend time trying to learn that story before I ever see a patient in my office, because that's important to me.
They're important for them.
It's important to it's the whole team dynamic, because it truly is a team dynamic. So when someone comes in the room, I introduce myself. I will sometimes ask some questions because I want to validate what I've seen and what I've read in their chart, what I've read in their information packet that they fill out at the very beginning, because it matters. That person that has lupus, that's had lupus for 25 years, may not think about that as being a condition that I need to know about. But if I see Plaquenil or something like that in their medication list, I'm going to ask them. And then I figure out, hey, that lupus probably isn't under great control. When was the last time you saw a rheumatologist? We need to get you to the rheumatologist because radiation is not going to be appropriate for you because that immunologic disease you have is going to prevent me from giving good treatment because you're going to have a lot of toxicity as a consequence. All of those things have to be balanced. And you can't ask the question if you don't know about it. You can't dig further into someone's history if you haven't taken the time to learn what it is. It is a group effort, it's a team effort. There's no on team. I throw that out there just because I had a personal trainer way back when who would say that to me all the time as I was sweating and wheezing through different weight training exercises. You are a team. Like, well, is there an ambulance outside? Because I need it. Anyway, I throw that out there anytime I can say, just because it sounds cool, but really, it is a team dynamic. I can't help you if you're not helping me to help you. So I really try to create an environment where we are having conversation so that we can share the information. I don't know if I answered your question or not. I live on a stream of consciousness, so forgive me. I don't know if I did or not.
Take podium and I can go home. That's what I thought. You did answer the question beautifully. I do have a question that came into the portal for you, Dr. Oles. And I think it's more, it's always a concern for whoever writes the question. And I think clarity is in addressing the question. A patient sent in a question about bolus in the setting of mastectomy that needs radiation because there were lymph nodes involved or the tumor had a close margin. For whatever that reason is, post-mastectomy to move towards radiation therapy to the breast to sterilize the areas. What does bolus imply?
Okay, so when we're talking about treating with radiation after a mastectomy, obviously we're looking at the area where the breast lived before because we're hoping to get rid of a microscopic disease that may reside on the chest wall where the breast was located. Understand that the concept of radiation in the post-mastectomy setting is really to address anything that might be left behind that was too small to have been seen on imaging or when the surgeon's there operating. I've spoken to surgeons over the years, and the best surgery that a surgeon can look forward to is that they don't actually visualize the tumor because it's enclosed in normal tissue and it's removed. So the only people that are seeing that tumor are the pathologists when it gets to the lab. So radiation in that sense is really a preventive measure. It's kind of a clean measure because the hard work has been done. Local control is important, so that's why it's not neglected. Bolus is actually a physical entity, and it's placed on the chest wall because you don't have a breast anymore. Now, instead of having a breast as a target for the radiation, the skin is the target. The soft tissue is the target. Because if there are cancer cells remaining on the chest wall, that's where they're going to be. So the bolus actually allows that dose of radiation to make it to the skin itself. I will not bore you with the physics of radiation, but I will tell you that there's a space that exists where you do not get the dose yet. It's a physical space. It's small, a couple millimeters. But if you neglect to make up for that missing space, that means you're sparing some of the skin on the chest wall, i.e., you're sparing some of your target from getting total dose. So bolus makes a difference when we're looking at dose distribution. Forgive me if I'm putting any of you to sleep. I am trying to make this somewhat interesting. When we talk about radiation therapy, we're always concerned about the dose and the percentage of the dose that's getting to the area it needs to. We are obviously concerned about normal organs in the area that we're treating because they're just as important. I haven't done you a favor if I've caused you irreparable harm, but I cured your cancer. I got rid of anything that was left behind. So there is a balance. It is unacceptable to have dose to the skin in a post-mastectomy person. That's less than 70%. And that's what you end up getting the majority of the time if you don't use this physical material called bolus to lift the dose up to the skin. So there are some institutions that don't use bolus, but typically those institutions may not use it because of the person's body habitus. If your chest wall is more than I don't remember the exact number of millimeters, forgive me. No, it's actually centimeters. If your chest wall is less than 4 centimeters in thickness, you actually don't need bolus because that electronic equilibrium point is actually so superficial because of your depth tissues, you don't need it. But 4 centimeters may not sound like a lot, but that's a decent amount chest wall. So the majority of people are benefiting from bolus. And if you're wondering whether or not that's considered during the treatment planning process, it actually is. When the magic happens, that's that period of a week to a week and a half after the treatment planning session, when the dosimetrist and the physicist and I are sitting down coming up with the best possible treatment plan. We look at a plan with bolus and without bolus. And inevitably, having the bolus gets a higher dose to the skin, which again is the target. The difficulty with that when you're receiving treatment is your skin is a target, your skin is getting red, it's getting irritated. So that target is also something you are physically aware of every day that you're getting your radiation. Every day that you get further into your course, you're noticing it's pink, it's red, it's irritated. You get this prickly heat rash that's itchy and burning all at the same time. And you're wondering why it's progressing. It's because it has to progress because it's target. That's not a really acceptable answer, but it's true. There's really no way to get good dose to skin if you aren't getting good dose to the skin. So that's what bolus is. It really is a physical material.
Thank you, Tia. Another question that came in, and this is for Dr. Plitas and Dr. Rourke. And you can prefer, that'll be your not going to get $1 million. You can confer. Patient writes in the same setting, I've just had a mastectomy. Why would I need anything? There are no more breast cells left behind. So take it.
I think we're going to say the same thing.
Yeah.
Go ahead.
There's this pathologic entity, which is something called lymphovascular invasion, where you have a mass of tumor cells, and then if you look at the surrounding tissue, even the skin, you can see isolated tumor cells scattered about the tissue. And those tumor cells can actually extend all the way into the skin. They can extend into lymph nodes farther away from the surgical field, and they could be a nidus for a local occurrence down the road. And we can't remove all the skin. We can't remove all the lymph nodes, some of which extend deep into the chest. And even when we did try to attempt that, it didn't actually make much of a difference. That's what radiation gets to. Radiation gets to those things that we physically can't. And there are some people who don't need it. And we're able to sort of risk stratify people based on the stage, so how big the tumor was, whether or not there was lymph node involvement, some pathologic features, to try to understand who is at higher risk of local recurrence, who's at lower, and then treat accordingly with the radiation. But at the end of the day, the radiation really kills the tumor cells that we just can't get to.
And I'd just add, we as surgeons, when we do a mastectomy, we remove all of the breast tissue we can see, but we cannot see cells. And so I always tell patients, there are breast cells left behind. We see the tissue we can see. And so, that's why radiation and surgery are good partners when needed.
Wonderful. We're going to take the last 15, 20 minutes of this session to actually focus below the waist. And I'm actually going to ask and abuse Dr. Jean Carter, if you'll come up. Yes, I'm going to abuse you twice today. I'd like to introduce, and thank you so much for being here, Dr. Tana Bradham. She is a GYN oncologist, gynecological oncologist, who is at New York Oncology Hematology, who was kind enough to come in when Dr. Heidi Godoy could not make it today. I will say, Tana, I'm getting rave reviews about all the patients that are seeing you. So sometimes we need a pat on the shoulder, and you've got one on each shoulder. Okay, thank you. Thank you for what you're doing. And Jean, Dr. Jean Carter is a clinical psychologist and certified sexual therapist. and she provides individual interventions for women with cancer. She's the chief of division at Memorial Sloan Kettering Cancer Center. And I just wanted to make sure that when Dr. Pradam is talking about her patient population, that I'm not going to be dragging you up here. So just have a seat and be comfortable, okay? Tana, so many patients that are diagnosed with breast cancer come back to the surgeon and come back to me, and they say, well, should I have a hysterectomy too? Should I have my ovaries taken out? Will I live longer? And I'm sure you get that a lot. Can you talk to that? That was one of the questions that came in.
Yeah, thank you. The question. I think obviously we always have this intuitive connection that the gynecologic organs and the breast are inherently connected, and it totally makes sense, right? From when somebody's diagnosed and they're just like, okay, I just want it all out, because they'll come to us and they're like, I just want it all out. And so we kind of have to parse out exactly, what's going on with the history. Certainly one of the biggest things, as we know, is genetics, right? For those who are undergoing testing, if we have a patient that does have a BRCA mutation, then that's certainly a discussion for surgery where we talk about removal of the tubes and ovaries. Again, anatomically speaking, the tubes and ovaries, it's all connected to the uterus, but that doesn't necessarily mean that we have to have a hysterectomy. And so when people come in the setting of, say, genetics and it's indicated and we're doing a oophorectomy for that, we'll talk about a few indications. Certainly for any woman who's had, apart from a breast diagnosis, apart from a genetic diagnosis, if there's fibroids, if there's abnormal bleeding at baseline, if there are any other gynecologic issues at baseline, then that's kind of a no-brainer. If we're going in, removing tubes and ovaries, yeah, we do that all together. We often do that in a minimally invasive fashion, often laparoscopically or robotically, where recovery from hysterectomy is not as bad as people tend to think when they walk out of our office after counseling. They're like, oh, okay, it's not bad, and they tend to do fairly well. But that's sort of one thing. The other thing, there's some older data to suggest, if we look at large populations of women, there's a slight increase in uterine cancers with BRCA patients, but there's been no, from a slightly increased incidence of sarcoma, but there's been no definitive data on that. So I'll counsel patients in a BRCA setting that, what else is happening in your GYN history, and with this small increase, do you want to go forward and have more surgery? Because certainly more surgery is just always more risk. And for a woman who's not, if the genetics is negative and we don't have any concern about BRCA, again, it just goes to other gynecologic conditions. Is there any concern, bleeding, fibroids, etc.? And lastly, I think the other indication for a hysterectomy is really the endocrine management. So as I'm sure we'll be touching on various points of this conversation today, with endocrine therapy, and especially women who are on tamoxifen, if there are any issues, bleeding, intolerance, et cetera, then that's also a large percentage of patients that we get when we're talking about a hysterectomy per se. I think that's the hysterectomy portion. Yeah.
So a patient is carrying a genetic mutation, whether it's the BRCA1, BRCA2, BRIP, whatever, and they're referred to you for prophylactic surgery. All right. And what do you discuss with the patient prior to the surgery insofar as their expectations post-op, especially when they're only 35 or 40 years old?
So I think the first thing is that, when we have somebody with these genetic mutations, we have guidelines, because the question is, when is really the right time? So we have guidelines to say, okay, BRCA1, BRCA2, what is the age range? But every woman is different with respect to what's happening with fertility, what's happening with their family, right? And so, we do have screening, for lack of a better term, for high risk, where we do the combination
ultrasound exams, CA-125 monitoring. I mean, just continued, surveillance. But I think timing is really essential. People think that there's just this magic switch that, okay, I'm 35 and I'm BRCA1, I have to have my ovaries out. Well, it depends because, fertility is a huge question. So we definitely want to make sure we address fertility issue. Secondarily, it's, understanding out premature menopause and going into surgical menopause. What's the plan? Because I think it's very difficult to go ahead and do the surgery and then deal with the side effects without having that counseling, right? So we do talk about what are the options. If somebody obviously doesn't have a personal history of breast cancer and we're doing this prophylactically, then we have some options, right? We can talk about what replacement would look like. And we talk about that early and in the beginning because we don't want to wait till afterwards and not have that expectation. And
Can you speak to also the black box rule from hormone replacement therapy in those patients who are not diagnosed with breast cancer?
I think that there's just been, I guess what I can say about there's just been a lot of fear and uncertainty about the data, about old data from the WHO study, which I'm sure all these folks can go into it a lot more and slice and dice it than even I can, but needless to say, that black box warning comes from, some data from a study that is older, had different type of hormone than we actually use now, and in an older population where now we know we want to start earlier. And so I think with that removal, I think a bit of a veil is lifted. I think it's just more, now in the education of our folks who are in the medical field to not be as afraid. So yeah, I think that has actually helped in our counseling and especially for women coming in situations that we're just talking about now.
I'm certainly going to address in the fourth panel the issues of hormone replacement therapy as well as the new information that's come out regarding progestins versus estrogens, the pros, cons, combinations, singlets, what's appropriate for a postmenopausal woman, what's appropriate for a young woman. And again, the caveat is if somebody has been diagnosed with breast cancer. Jean, I kind of have you up here as a fail-safe for me, but you see these patients. You see the patients that go through prophylactic surgery or surgery for a reason. It could be a GYN surgery, which I would like to address in a couple of minutes. And do you find that I think it's an unmet need, so I'm going to prejudice it. Do you find that you're getting referrals from providers who are often busy, seeing 20, 30 patients in a day, have given maybe bad news? Do they take breath in a tertiary center like Memorial Sloan Kettering Cancer Center to say, well, part of your team is going to be your service? We kind of touched on that dinner last night. So
are you talking about specific to the risk population?
Can you hear out there? Okay.
Because you're talking specific to the high risk population. Obviously, one thing that we didn't mention was there are a lot of women that are now choosing to do sepingectomy, which is just removal of the tube and then to have your ovaries removed later. And there are two huge trials. The WISP trial looked at that, and they found that obviously women did better from a sexual function standpoint. And there's a huge cooperative group trial now going on, Rourke, which is hoping to answer more of these questions. So I think that the Voice of Women has pushed the medical field really to look at different opportunities and compromises so that they can not experience some of these acute side effects of menopause. So if I'm seeing someone in regards to that with high risk, a lot of times the doctors are comfortable, and please forgive me because they would come to you and talk to you about this. So if I say anything correct, feel free to correct me. But taking out the ovaries and doing a supplementation, HRT, will be much lower than what they thought perhaps they were having. So in that particular population, HRT is a very reasonable conversation and does have many other health benefits. it may not be enough to translate to the vagina. So we do talk about other options. We have a lot of data to support non-hormonal strategies, which work quite well if women get the education about what to use, where to use it. I'm hinting at vulva. I'll talk about that later, but everybody forgets vulva. And at a high frequency, because these treatments that are over the counter are really for women going through a natural menopausal transition. And that's not what our ladies experience. It's a drop off. And of course, low dose vaginal estrogens, again, with the blessing of the medical oncologist in a cancer population, can be used very safely and reasonably. But again, it's just having these conversations and talking with patients and making sure that they have information so they can ask the right questions and that we understand how to bring it up and offer solutions as well.
Yeah. And I think, Hannah, with your interest in developing a survivorship program and addressing a lot of these unmet needs of this part of the world, I think going to be huge. I applaud you. And there to back up in any way you want. I think it'll be important for all of us in medical oncology, surgical oncology, and just for everybody who is a community participant, whether they have cancer or not.
I would just give a plug because I think when we create these formal programs for survivorship, it really does create more equity for the population. Because, obviously there are some women who are lucky enough to advocate for themselves, who recognize symptoms or early stages when they're in perimenopause, when they should be, starting to seek care and treatment. But not every woman, is able to do that and to have a voice for themselves. And I think by creating these formal programs with criteria and pulling women into, just a survivorship visit, a formal visit where we do go over very specific things and screen for things, I think that's really going to take care of population better.
What saddens me are the women who are knowledgeable, who are in tune with their needs and their body, and then don't have facilities, don't have the program, don't have those needs met. And that's what we really have to strive for up in this part of the world, in the Hudson Valley and the Capital District. It's long overdue. So with that, we're going to take a break. I thank you all for being out here. Obviously, I'm going to abuse the two of you a little bit more. So thank you, Dr. Plitas, so much for being here. Dr. Rourke, I think your book is going to be a smash everywhere. Can't wait for number 2 and 3. Tia, just adore you. You make scary things so unscary. And if you ever retire, I'll be retiring the next morning because I need you for all the patients that I see. Tana, we're going to be in the next session together, Jean, this afternoon. Although I'll probably be up for the next one too. So everybody take a break. Let's be back here. Give them a good round of applause. How's this working, this forum so far? Hey, good. Okay. So let's take a break and be back here at 10:41 so we can start 10:45. Okay, thank you.